So, what's up, y'all? Back with chapter 16, therapy and treatment. So, therapy and treatment. There are many forms of therapy that have been developed to treat a wide array of problems. These are Marines who served in Iraq and Afghanistan, together with the community of mental health volunteers, are part of the Ocean Therapy program at the camp of Pendleton, a program in which learning to serve is combined with a group discussion. The program helps vets recover, especially vets who suffer from post-traumatic stress disorder. So, mental health treatment, approximately 19% of the U.S. adults and 13% of adolescents aged 8 to 19 experience mental illness in a given year. The percentage of adults who receive mental health treatment in 2004 to 2008 is shown below. Adults seeking treatment increased slightly from 2004 to 2008. About 1/3 to 1/2 of the U.S. adolescents with mental disorders receive treatments with behavior-related disorders more likely to be treated. Oh, by the way, this is the last chapter. I didn't say that, but yeah, as you can see through the years, it's been a pretty linear slope, but it's nice to see that it's slightly getting better, that people are coming to realize that we need treatment, and it's been heavily stigmatized and heavily depicted in some sort of negative manner, like sort of like stigmatizing and like deeming it like that. Oh, if you need to go to therapy, or if you need mental health, you're insane. Or no, I want to stay by myself. I need myself. I don't need help from some external source. That's a lot of the reasons why a lot of people don't like even going or inaugurating to go try to take a lot of this mental health treatment. But we'll dive into that more later. But the U.S., so approximately 90% of U.S. adults and 30% of adolescents age mental. So the percentage of adults who receive mental health treatments in 2004 to 2008. So it's pretty much the same thing, but this is just a different graph. It shows that the U.S. mental health treatment, age 8 to 6, sources of National Institute of Mental Health, NDC. You can see that the percentage of people with disorders. You can see the percentage of people with disorders from ages 8 to 9, or from percentage with the disorder and from the types of disorders. So anxiety disorders, mood disorders, conducting disorders, and ADHD and any other disorders. These are a lot of the treatments for a lot of the younger, more adolescent children. So treatments in the past. So treatments in the past were pretty vile. Obviously, not the most just, more of an erroneous treatment to trying to treat somebody with a mental disorder. So one of the treatments were exorcism, which involves incantations and prayers said over the individual's body by a priest and religious figure. Obviously, towards the 15th to 14th century, we thought that a lot of people were inhabited by these demonic spirits or these supernatural beings. We had these superstitions. So obviously, a lot of people then would assume that they'd done something wrong or there was a demon inhibiting them. So they performed exorcisms and obviously repeated a lot of incantations or enunciated a lot of incantations because they thought that there was something inhabiting. They thought there was this demon inside them. And trephining is just putting a hole in someone's skull and trying to release the demon. So they thought that you could put a hole in someone's skull and you could outlay a lot of these demons that were inside of these people's brain or inside of these people's heads so that disorder would go away. But obviously they didn't have a sufficient amount of treatment then, so it ended up killing the person most likely. So next in the 18th century were asylums. So the first institution created by a specific purpose of housing people with psychological disorders focused on ostracizing them from society rather than treating them. Individuals often kept in a windowless dungeon chained to a bed with little to no contacts and caregivers. Here's a painting by Francis Goya called The Madhouse, depicts a mental asylum and its inhabitants in the early 1800s. It portrays those with psychological disorders as victims. So basically in the 18th century, there was these things called asylums, which you're going to probably see most likely in movies a lot. And you'll see a lot of people have this sort of stereotype. Oh, yeah, you need to go in a mental asylum. That's where it comes from. It comes from the 18th century mental asylums where people stuffed a lot of these people with disorders and a lot of these people who were obviously not stable into an isolated place and ostracized them from humanity. And obviously, if you isolate a human for a long time, it's going to start to create a lot of these odd, weird, eerie, strange, and just just unstable humans, even more unstable than they were before they went into the asylum. So obviously you do not want to isolate a human in an asylum. But after this, there was deinstitutionalization, and that obviously created a lot of these psychiatric hospitals. But the psychiatric hospitals didn't have the sufficient amount of credentials, and a lot of these people didn't even understand how to assess people with disorders and things of the sort. So it ended up pretty much subsiding, honestly. But in the 18th century, French physician argues for a more humane treatment of mental illness. It suggests that to be unchained and talked to, it was implemented in Paris in 1975. Patients benefited, and many were able to be released from the hospital. So this painting by Tony Robert Fury depicts Dr. Philippe Pinot ordering the removal of chains from patients in the Salvatierre Asylum. I cannot say that. That's French, in Paris. So basically what this was depicting was that it was more trying to get them from being ostracized and having a discourse with these people who were deemed to have these disorders. It was obviously a more rational way, or probably one of the most rational ways in the 18th century that we can think of in this depiction right here. But in the 19th century, Dorothea Dix, a social reformer who became an advocate of the indigent insane, investigated the state of care for the mentally ill and poor. She discovered that the underfunded and underregulated system that perpetuated abuse of mentally ill. The instrument in creating the first American mental asylum by relentless lobbying of legislators and Congress to set up a funded institution. So basically what Dorothea Dix did was a lot of these institutions and psychiatric hospitals were underfunded. So what she did was she set on an adventure, if you want to call it a quest, to lobby a lot of these political higher ups, so that we could actually get a sufficiently funded psychiatric hospital for a lot of these people with disorders and a lot of these mentally ill patients. But American asylums were usually filthy. They offered little treatment. Individuals were institutionalized for decades. Treatments were submersion into cold baths for long periods of time, electroshock treatment, now called electroshock therapy, and it involves brief application of electric stimulus to produce generalized seizures. Conditions such as these were common until the 20th century. So 20th century, 1954, antipsychotic medications were introduced and proved successful in treating symptoms of psychosis. Psychosis was a common diagnosis evidenced by symptoms such as hallucinations and delusions, indicating a loss of contact with reality. So, in 1975, the mental, I can't say that because I'm on Roblox right now, but Facilities and Community Mental Health Centers Construction Act. But basically what this means is sort of slow. This means you can't catch on quickly, but provided federal support and funding for a community mental health center. It started with the process of deinstitutionalization, the closing of large asylums by providing for people to stay in their communities and be treated locally. Patients were released, but the new system was not set up effectively. Centers were underfunded, staff untrained to handle severe mental illness, and it led to an increased homelessness. So yeah, like I was saying earlier, a lot of those institutions were defunded, and since they were defunded, they didn't obviously have the effective staffs. They were underfunded, so they didn't have sufficient funds and sufficient resources. And that just is going to lead to a lot of homeless people and a lot of people who have disorders who don't know what to do with their life because they're cognitively impaired. So what can they do but be homeless? So mentally illness among the homeless population is still common today. Of the homeless individuals in the U.S. shelter, about 1/4 have severe mental health illness. Correctional institutions also report a high number of individuals living with mental illness. So yeah, you'll see a homeless person speaking to themselves. They most likely have a mental illness because they're cognitively impaired, which means they can't go and do things day to day. They have a lot of atypical symptoms that impair them in a negative aspect. So asylums have since been replaced with psychiatric hospitals, and local community hospitals focus on short-term care. Emphasis on short-term stays an average stay of less than 2 weeks due to high costs, psychiatric hospitalization, insurance coverage over limits, lengths of time individuals can be hospitalized. Individuals are usually only hospitalized if they are an imminent threat to themselves or others. Most people are not hospitalized but can still seek psychological treatment. Involuntary treatment therapy is not an individual's choice. Example, weekly counseling sessions might be conditioned of parole. Voluntary treatment, the person chooses to attend therapy and to obtain relief from the symptoms. Sources of psychological treatment, community mental health centers, private or community practitioners, school counselors, school psychologists, or school social workers, and group therapy, which we'll get into more. We'll get into a lot of the group therapy and a lot of the voluntary and involuntary treatments that people will go through. So, treatment providers include psychologists, psychiatrists, clinical social workers, and marriage and family therapists. Still, a lot of people don't really know what psychologists and psychiatrists are, but I'd say psychiatrists are more psychiatrists for illness, disease. They're the people who are going to give you the diagnostics and the diagnosis for the illness, and a lot of the psychologists are going to be the people who are going to be giving you that therapeutic measure, the CBT and things of that sort. So, psychodynamic and psychotherapy was a talk therapy based on the belief that the unconscious impacts a childhood and impacts behavior. Patients talk about their past. So this is more the Freudian aspect of therapy. We're going to deep down look into your repressed thoughts about, or your repressed behaviors that you don't know, to help you get higher interpersonal intelligence and make you realize what's wrong with you so the psychologist can fix what's wrong. Play therapy is a psychoanalytical therapy wherein interactions with toys is used instead of talk. This is mostly used in child therapy. Play therapy can get a child to open up, a child to release cooped up feelings. So a therapist is able to easily percolate inside and see what's inhibiting this child from doing the normal functions that the child is supposed to do. Patient child acts out of family scenes with dolls. Or they could act out scenes with dolls, and the psychologist could see what's wrong with the child. Behavioral therapy, principles of learning applied to change undesirable behaviors. So this is more likely associated with CBT. CBT is more trying to get into the depths of what's wrong with the person. So we're going to see these negative behaviors, these negative aspects, things like, oh, I don't like myself. Oh, this is that. Oh my God, I'm just so not intelligent. Blah, blah, blah. And we're going to turn around. We're going to try to decrease these paradigms within this person's cognition. Patients learn to overcome fear of elevators through several changes of relaxations and techniques. And behavioral therapy can also be a lot of classical conditioning where somebody is put in this sort of vivo thought where they think about something and they go back and try to associate it with something that's relaxed and happy, something that's just not as vile, obviously. So cognitive therapy is awareness of the cognition, the process that helps patients eliminate thought patterns, and it leads to stress. Patients learn not to overgeneralize failure based on a single failure. So cognitive therapy can be a lot of cognitive therapeutic measures can be trying to access a lot of these general thoughts that a lot of people have, and it tries to get rid of a lot of these patterns and paradigms that people have. Whereas behavioral therapy tries to help a behavior, but cognitive therapy and behavioral therapy, I say, could be really relative, because obviously if you're going to have a cognition and a belief, it can sort of develop and it can add or be added as a substrate to your behavior and how you're going to be acting and reflecting in real life. So cognitive behavioral therapy works to change the cognitions and distortions and self-defeating behaviors. Patients learn to identify self-defeating behaviors to overcome an eating disorder. So what this does is they try to recognize the distortion, what's impairing them from doing this, what's impairing their thought and ideation, and we're gonna remove this self-defeating factor by maybe gradually or subtly getting rid of this cognitive or this cognitive impairment. And we're going to learn to identify those defeating factors, and we're going to learn ways to overcome. We're going to learn a way to overcome. If you learned how to get that cognitive impairment, you can learn how to get rid of that cognitive impairment. Humanistic therapy increases self-awareness and acceptance through focus of conscious thought. Patients learn to articulate thoughts that keep her from achieving her goal. So, humanistic therapy, in this example, this is pretty much a free association example. This is more trying to get that self-idolization. You're gonna try to see. I hate to bring in the Maslow hierarchy, but you're going to get that self-actualization. We're going to see your self-actualization. We're going to see your potential. We're going to see what can make you a better person. And we're going to increase your self-awareness. Obviously, we're going to increase your interpersonal intelligence and things of the sort. And we're going to articulate a lot of those negative aspects that make you or impede you from seeing that self-actualized state. So next is psychoanalysis, which first formed in psychotherapy, developed by Sigmund Freud in the early 20th century, aimed to help uncover repressed feelings. So techniques can be free association, dream analysis, transference, and that's pretty much it. So free association is where a patient relaxes. They're going to sit on a couch. Maybe they're going to sit away from the psychologist so there's not direct contact to alleviate some of that tension. And what we're going to do is the psychologist or the psychoanalyst is going to tell the client, speak your mind. What's wrong with you? What do you need help with? You know, what's impairing you? What do you feel like is making you feel this way? And the patient is going to speak. They're going to speak their mind, and it's going to help the psychoanalyst get a feel for what's wrong with the client. Dream analysis, therapist interprets the underlying meaning of dreams. So dream analysis, we really don't have a big complete objective understanding on dream analysis yet. And what really underlies dreams, that's more still in the theorize and the hypothetical stuff. That's more in that realm. But next we have transference, which is when patients transfer all positive or negative emotions associated with other relationships to the psychoanalyst. So what this is going to be is they're going to transfer a lot of that negative or positive emotion towards the client. They're going to transfer that negative emotion. They're going to say, hey, I hate you. Hey, you're this, you're that. Oh, my dad does this. I just hate how he does this. And you're just going to act like this person is the person you're irritated at or mad at. And you're just going to transfer a lot of those feelings. It's pretty much displacement towards the psychoanalyst. So psychoanalysis is less popular today, but Freud's perspective has been expanded upon, incorporating modern theories and methodology, psychodynamic psychotherapy, talk therapy based on beliefs in the unconscious, childhood conflicts that impact the behavior. So, psychoanalysts, this is a famous couch Freudian's consulting room. Patients were instructed to lie comfortably on the couch and face away from the Freud in order to feel less inhibited, and that helped them focus. Today, in the psychotherapeutic patient is not likely to lie on the couch. Instead, he's more likely to sit facing the therapist. So, you think of therapists, you're most likely going to think of this chair where the client was instructed to sit on the chair and just confess his feelings, get more of that free association. And so the psychoanalyst could find out what's going on with this client. You know, it really helps. It helps the client release a lot of those pent up feelings. And it also helps the analyst find out and capture and procure what's going on with the patient. So play therapy, we're going to go more into play therapy, psychoanalytic therapy, where an interaction with toys is used to talk. This is most likely used in child therapy. It's used to help clients prevent/resolve psychosocial difficulties and achieve optimal growth. Toys such as dolls, stuffed animals, and sandbox figurines are used to help child play out their hopes, fantasies, and traumas. So sand play and sand tray therapy, children can set up three-dimensional world using various figures and objects corresponding to their inner state. Therapists observe how a child interacts with the toy in order to understand the roots of a child's disturbed behavior. We can use this to make a diagnosis. Non-directed play therapy. Children are encouraged to work through problems by playing freely while the therapist observes. And direct play therapy, a therapist provides structure and guidance by suggesting topics and asking questions. So a directive therapy is more direct, like in its name. It's trying to penetrate, and it's trying to extract that factor and elicit that factor that's making this kid feel this way, or that's impeding this child. And non-directed play therapy is when the children are just encouraged to work through problems. And pretty much this just shows the psychologist, without the psychologist saying anything, just observing what the child is doing with the dolls and the toys and observing the acts that he's doing to try to find out what's going on with the child. Like, this actually reminds me a lot of the study we did in previous chapters where the kids were learning a lot of vicarious learning, and then they started punching the doll after seeing what their doll did. So if we can find out, like, a lot of the things that this child's doing by observing vicarious learning, maybe we can see that there's a lot of abuse going on in the household. So next, behavioral therapy. Principles of learning are applied to change undesirable behaviors based on the belief that dysfunctional behaviors can be changed by teaching clients more constructive behaviors. Classical conditioning is conditioning principles that are applied to recondition clients and change their behavior. So we're going to do classical conditioning and operant conditioning in this chapter again, because those are some pretty important topics. So counter conditioning, a client learns a new response to stimulus and has a previous elicited an undesirable behavior. This includes aversive conditioning and exposure therapy, which we will get to more of the aversive conditioning and exposure therapy. But I can tell you, oh, never mind, it's literally right here. So aversive conditioning, I'll give a summary. Aversive conditioning is basically using some unpleasant stimulus like a electric shock. And we're going to associate this electric shock with this desirable habit that we have, this negative desirable habit that we have, such as substance abuse. If we conflate substance abuse and electric shock, which is pain, and some people don't like pain, then we could create some unpleasant reaction, and it can embed inside a person's mind to associate the electric shock and the electric pain with the substance. So this is used to eliminate addictive behaviors. Client is repeatedly exposed to something unpleasant, such as a mild electric shock or bad taste, while engaging in a specific behavior. And what they mean by bad taste is when someone puts some disgusting some disgusting thing on their nails, and if someone tends to bite their nails, it can cause them to conflate the terrible taste with biting their nails, and that's going to entice them not to bite their nails. So anti-abuse, which is a substance that causes negative side effects such as vomiting, when combined with this substance right here, it has been used effectively to treat alcoholism. So yeah, anti-abuse, definitely something I'd recommend if you have substance abuse. So exposure therapy seeks to change the response of a conditioned stimulus. This is used to treat fears of anxiety. A client is repeatedly exposed to an object or situation that causes a problem with the idea while eventually getting used to it. So what I learned is that you cannot be nervous and you cannot also be relaxed at the same time. But what exposure therapy does is exposure therapy tries to reduce this anxiety when you see this object. So here's going to be a visual representation of exposure therapy. It's going to be a rabbit. So this boy he sees a rabbit and he gets a fear response from the rabbit. And when he sees cookies and milk, this boy is going to be happy. When it's cookies and milk and rabbit, the kid is I want to say he's going to be happy or anxious. But as he conflates them over and over again, and what in this Jones study, the rabbit actually gradually came closer day after day. So the child could conflate these two topics and create this bunny, and see this bunny in a positive aspect rather than seeing this bunny in a negative aspect and having that fear response. So, I mean, that's pretty cool. Like, that's pretty cool how you could conflate two things and make your brain. I mean, we are association creatures, but that's pretty cool. So, but I'll read it. Repeated exposure, Peter to a rabbit while he was eating a snack in a relaxed state. The rabbit started in the cage on the other side of the room, and over several days he gradually moved closer to Peter while he ate his snack. After 2 months, Peter was able to pet the rabbit while eating the snack. So exposure therapy, Refined Jones technique developed a version of exposure therapy. This therapy is called systematic desensitization, which is a type of exposure therapy when a calm and pleasant state is gradually associated with increasing levels of anxiety and inducing stimuli. Fear for relaxation are incompatible. If a client can relax around fear-inducing stimuli, the unwanted fear response will eventually be eliminated. A client is taught progressively relaxation, how to relax each muscle group and achieving a relaxed and comfortable state of mind. Progressive relaxation is used while a client images anxiety-inducing situations. Over time, progressive relaxation helps the client become desensitized and anxiety-inducing stimuli. So basically what this is saying is that honestly, what we saw in the last chapter was a desensitization approach, which the client is taught to associate something with a relaxation technique. So what we're going to do here is we're going to imagine a spider. We're going to imagine a spider. What the therapist or the psychoanalyst is going to do is he's going to tell the person, hey, think of the best thing you can think. Think of your happy place, relax, calm down, everything's going to be fine. That's pretty much what we're going to be doing with systematic desensitization. We're going to be trying to conflate something negative and causing some sort of relaxed state or some sort of tranquil serenity state, where the client is going to associate this relaxed state with this negative stimuli, and soon he'll have this conditioned response, and he'll conflate these two, and he'll become desensitized. And then there's also virtual reality exposure therapy, which is a use of stimulation to help conquer fears. And if this is most likely used if it's too impractical, expensive, or embarrassing to recreate anxiety-inducing situations. Yeah, and here was a rating scale for spiders. So the fear from a photo of a spider was 15%, or a 15 rating. Looking at a spider through a clear glass gave a 35% fear rating. Holding a box that contains a spider gave a 55% rating. Watching a spider crawl across the floor gave a 65% rating. Watching a spider crawl across your desk gave a 75% rating. Holding a spider with gloved hands gave a 90% fear rating. And last, holding the spider with your bare hands gave a 100% fear rating. So, operant conditioning was based on the principles of behavior becoming extinguished when not reinforced. Applied behavior analysis operant conditioning technique is designed to reinforce positive behaviors and punish unwanted behaviors. Effective in helping children with autism. Children-specific reinforcers, stickers, praise, candy used to reward and motivate autistic children when they demonstrate desired behaviors. Punishment might discourage this unstable behavior. Token economy was used to control settings such as psychiatric hospital. Individualizations are reinforced for desired behaviors with tokens, poker chips that can be exchanged for items or privileges, often used for psychiatric hospitals. So what this is saying is that we're going to use operant conditioning, which is reinforcements and punitive measures to entice somebody to do a negative thing. To entice somebody to do a positive thing, not an erroneous thing. We're gonna give them a reward if they do something good, and we're gonna add a punitive measure if we're gonna do something bad. So we did this in our learning module, in our learning chapter, operant conditioning and classical conditioning. But we'll probably get more into it in later chapters. So cognitive therapy, developed by Aaron Becker in 1960s, based on the idea how you think determines how you feel and act. Cognitive therapy focuses on the thoughts and feelings of distress. So cognitive therapy, you might see this on your test. I saw it on mine. What underlies cognitive therapy is going to be how you think is going to develop how you act. So your cognition is going to shape your behavior, or your cognition, or it's behavior consequence. ABC model: action, behavior, consequence. So emotional reaction. So it encourages clients to find more logical ways of interpreting situations and positive ways of thinking. So we're going to be more trying to apply or have these more applicable, optimistic behaviors that we can put into a situation, so the client is going to feel better and think better thoughts. Cognitive therapists help clients become more aware of their cognitive distortions and thinking errors. Overgeneralizations is taking a small situation and making it huge. Prominent overgeneralization is when a bad encounter happens to a woman from a man, or when a bad encounter happens from a dude to a woman. They're going to say, oh, all men do this, all women do this. This is an overgeneralization. Polarized, black and white, dichotomy. It's thinking that there's either going to be something completely positive or something negative. Either I'm going to win this or I'm not. That's it. Either I pass this test or I'm a DUMB. So it's either perfect or failure, common in depression. So jumping into conclusions can be assuming that people are thinking negative about you or reacting negatively to you without evidence. So jumping to conclusions is a lot in the schizotypal order, if I'm not mistaken. I might be, but the personality disorder where you're overthinking about a lot of the things that happen because you have this sort of unique, this sort of quirky personality. So, or this niche personality. So you do a lot of niche things, and you think that people are critiquing you all the time for these niche things and these weird things. So it causes this sort of avoidant persona to arise in you, and it causes you to not want to be around people because you have a lot of these eerie, just odd aspects of you. So clients are helped to change dysfunctional thinking patterns by challenging irritational beliefs, focusing on their illogical basis and correcting them with more logical and rational thoughts and beliefs. So next, this is the cognitive therapy. So failed tests, internal beliefs, I'm worthless, and depression. Failed tests, internal beliefs, I'm smart, but I didn't study for the test and I can do better. So we covered this in a lot of chapters. I like to think of this as the misattribution error, or something like the actor-observer bias. So, but it's not exactly those. But it's like we're gonna fail a test and automatically conflate it with some internal belief. Say we have no skill. Say, oh, I'm never gonna be smart. Blah blah blah. This, no matter where I go, I won't be smart. But failing a test and having the internal belief that, hey, it's not that I'm not smart. There's an external factor. I just needed to study for the test, and I couldn't have failed. You know, I can do this. You know, and this is going to lead to no depression. So next is a cognitive behavioral therapy, which there's going to be rational emotive therapy, RET. Unlike other forms of psychotherapy, cognitive behavioral therapy focuses more on present issues rather than the patient's past. There's going to be cognitive behavioral therapy, which rational emotive therapy works on rational emotions. Like the guy I was watching really had a good example of this. Like he's going to say, oh, why are you scared of spiders? Most spiders can't even penetrate your skin. You know, it's totally irrational and illogical to be scared of spiders. You know, why are you scared of a spider? He can't do anything. The small thing you can step over with your foot. Why are you scared of a spider? You're acting illogical. You know, and this I would think is a really likely, and I would think this is really helpful for a lot of the analytical people, a lot of the objective people, a lot of the scientists. You know, having this rational emotive therapy. But cognitive behavioral therapy works to change cognitive distortions and self-defeating behaviors and aims to change both how people think and how they act. This helps clients examine how the thoughts affect their behavior. A combination of cognitive therapy makes individuals aware or irrational of negative thoughts and replacing them with positive ways of thinking. And behavioral therapy teaches people to practice and to engage more positively in healthy approaches to situations. So basically what this is saying is we're going to be replacing a lot of these negative thoughts, these negative patterns, and we're replacing them with positive patterns and positive ideations. We're going to put them more in an optimistic field of thought, or an optimistic cognition. So this uses the ABC model to relieve cognitive distortions, like I was saying earlier. CBT uses action, belief, and consequences. So action is the activating event, your belief about the event. If you believe that if you have, like we had before with the self-efficacy, if you're not motivated, if you feel that you can't do something, you're going to have that ramification. You're going to believe that you will never be able to do anything, and maybe you even generalize the topic, and we don't want to do that. So ABC model, your belief is going to shape your cognition or consequence, and that's going to make you think and act the way you do. Humanistic therapy focuses on helping people achieve their potential goals and increasing self-awareness and acceptance through conscious thought. So I like to think of humanistic therapy as driving towards that self-actualization. So getting people to have these better thoughts, getting people to realize the potential that they have, and getting people to understand what they could do in the world and what they could do to change the world. So Roger and client-centered therapy, developed by Carl Rogers, emphasized the importance of taking control of his own life and to overcome life changes. And this also embodies that locus of control. Okay, so non-directive therapist does not give advice or provide interpretations and helps the client identify conflicts and understand the feelings. So this is pretty much just a corroborative. Non-directive therapy is more a corroboration towards therapy. So direct therapy is going to be, a lot of these therapists are going to be giving you advice how to fix a situation, how to go by the situation. But maybe in the non-directive therapy, the therapist is going to listen to you. They're going to try to understand their feelings, and they're going to try to empathize and sympathize with you. So techniques can be active listening. The therapist acknowledges, and then they'll restate the sentence just to understand and clarify if they're on the right page with you. And it even helps the client, because the client can realize that, hey, this man's listening to me. This person actually cares about what I'm saying. So unconditional positive regard, therapist does not judge the clients and simply accepts them for who they are. So a lot of therapists are going to have this unconditional positive regard. But a lot of the, luckily with a lot of therapists and a lot of therapeutic institutions have it so you can actually pick your psychologist. So you probably won't have to worry about that. And so they're more lenient and more accepting of your beliefs. So genuineness, empathy, and acceptance towards clients. Roger felt that a therapist should demonstrate these because it helps the client become more accepting of themselves, which results in personal growth. So if you can become accepting, if the psychologist gives you that empathy and gives you truth and accepts who you are, this can cause you to accept who you are, because, hey, let's think about it. A lot of the things and a lot of the emotions that we have this cyclic nature. So if you can contribute some sort of emotion towards someone or someone else, that emotion can be reciprocated onto you. That is the reciprocity aspect, the thing that we talked about in earlier chapters. Reciprocity. So, biomedical therapies, psychotropic medications used to treat psychological disorders, treat symptoms of psychological disorders, but do not cure the disorder. So, antipsychotics treat a positive psychotic symptom such as hallucinations, delusions, and paranoia by blocking dopamine receptors. So atypical antipsychotics treat negative symptoms of schizophrenia, such as withdrawal and apathy, by targeting both dopamine and serotonin receptors. So a lot of these psychotics are positive or negative. So atypical you can think of as a negative by removing the bad aspects of schizophrenia, which is withdrawal, apathy, by targeting these receptors. They're going to delete, they're going to try to get rid of these negative aspects of schizophrenia, while antipsychotics, not atypical, antipsychotics are going to treat the positive symptoms, such as hallucinations, delusions, and paranoia, by blocking some of these dopamine receptors. Because usually it's just to access of a lot of this dopamine that's getting released towards this area or towards this region of the brain. So if we occlude these dopaminergic receptors, we're going to end up being able to cause a positive reaction, which is pretty much antipsychotics just block the excessive dopaminergic transfer, while atypical antipsychotics pretty much get rid of the withdrawal and apathy within a person. So antipsychotics and atypical antipsychotics are both traits of schizophrenia and types of several thought disorders. So antidepressants alter the levels of serotonin and norepinephrine, which norepinephrine is one of the stress hormones. Depression and anxiety, anti-anxiety agents depress the central nervous system activation. Anti-OCD, PTSD, and panic disorder and sociophobia. You'll see a lot of these are going to be central nervous system excitational disorders or things of the sort. So what this is going to do is it's going to alleviate and it's going to try to ameliorate a lot of these excited states in your central nervous system. Mood stabilizers are going to treat episodes of mania as well as depression. So a mood stabilizer is going to be for bipolar disorder. It's going to bring your mood back to a more stable state. Stimulants improve the ability to focus on tasks and maintain attention. ADHD. So if you're an ADHD student, you're most likely going to have these stimulants, and this stimulant is going to be something that's going to improve your ability to maintain and focus. So electroconvulsive therapy is going to be inducing these seizures, and what these seizures do is they activate a lot of the neurons in your brain, and these neurons, some of them and certain disorders aren't heavily activated, or they're not activated at the sufficient threshold that they need to be activated at. So what this electroconvulsive therapy does is it's going to excite these electrons in your neurons, or excite this electricity within your brain, and it's going to help you with a lot of that electroreceptor and electric transmission throughout the body, which is obviously going to put you in a more excited state. And this is obviously going to be helpful for severe depression. Transcranial magnetic stimulation uses magnetic fields to stimulate nerve cells within the body, and this is going to help improve depression symptoms. So if we use this magnet that's inside of your brain, it's going to induce a lot of these electrons in your brain, or these neurons in your brain, to get into a more excited state, much like electroconvulsive therapy, honestly. But treatment modalities. So therapists gather in specific information to address clients' immediate needs, presenting problems in the client's support system. Insurance status. Therapist informs the clients about confidentiality, fees, and what's expected in the treatment. Confidentiality. The therapist cannot disclose the confidential communication to any third party unless mandated or permitted to do so by the law. And that's most likely going to happen if you're going to say that you're going to commit, or if you're going to say that you're going to cause violence or infringe on someone's rights. Treatment goals are discussed and treated in plans and form. Therapy may occur one-on-one between therapist and client, or in a group setting, just like what we talked about with the ocean therapy. So treatment modalities, individual therapy. In an individual therapy session, a client works one-to-one with a trained therapist. Usually it lasts about 45 minutes to 1 hour, and the meeting occurs in a confidential environment. Clients might explore feelings of work through life challenges, identify aspects of themselves and their lives that they wish to change, and set goals to work towards these changes. Group therapy. In a group therapy, several clients meet with a trained therapist to discuss a common issue such as divorce, grief, and eating disorder, substance abuse, or anger management. This can help decrease shame of isolation. Clients may have concerns about confidentiality or feel comfortable sharing problems with strangers. Psychoeducational groups with strong educational components. Groups for children whose parents have cancer, which teaches them about cancer. So family therapy. There's going to be aims to enhance growth of each family member as well as the family as a whole. There's systematic approaches, which the family is viewed as an organized system, and each individual is contributing to a member who creates and maintains process within the system that shapes behavior. Each member influences and is influenced by each other. like I said, with that cyclic nature, one member usually has a problem that affects everyone. Substance dependence, and the therapist helps them to cope with this issue. So structural family therapy examines the discussion and the boundaries and structure of the family. Therapist helps them resolve issues and learn to communicate effectively. Strategic family therapy aims to address specific problems within the family that can be dealt with in a short amount of time. So couple therapy therapists help people work on difficulties in their relationship and aim to help resolve problems and implement strategies that will lead to healthier and happier relationships. How to listen, how to argue, and how to express feelings, primarily used in cognitive behavioral therapy. So CBT is going to be commonly used for family therapy. Initially, individuals voluntarily choose to use a substance. Chronically, substances can be used permanently and alter the neural structure in the prefrontal cortex, which addiction of substance can lead to thiamine deficiency, and you do not want thiamine deficiency because you will get this thing called you get a lot of things wrong with you. It's so much. I can't even bring it up right now. I can't even remember half of the things that happens when that happens. But a person becomes driven to use substance or making it difficult to stop. Relapsed individuals return to abusing the substance after a period of improvement. About 40 to 60% of individuals relapse. Individuals addicted to the substance or alcohol frequently have additional psychological disorders. Substance abusers are twice as more likely to have mood and anxiety disorders. People with psychiatric disorders may self-medicate and abuse substances categorized as mentally ill or chemically addicting. Problems are often chronic and treat has limited success. So a lot of people have dependency on a lot of substance abuse, but prevalence of substance use. So around these ages, the substance abuse tends to heighten. So around obviously 0 to 5, you're most likely not going to be using a substance, but as you get more into your adolescent stages, you're going to start using a substance more and more. Substance-related treatment goals to help addicting person stop the compulsive drug-seeking behavior. Requires long-term treatments more cost-effectively than incarceration, or not treating those with addiction. Substance use, the abuse costs in the United States over $600 billion a year. Okay, whatever. I'm just gonna keep going. So behavioral therapy can help motivate the addict to participate in treatment programs and reach strategies to deal with the cravings and how to prevent relapse, to detox the addict safely after an overdose, to prevent seizures and agitation that occur in detox, to prevent reuse of drugs, and to manage withdrawal symptoms. So substance-related treatment, a lot of these are just going to be effective ways to try to reduce the substance abuse, and these are just going to be coping mechanisms. So programs, group therapy is going to entice somebody, requiring long treatment and more cost effective than, okay, so I don't know why I'm confused right now, but the goal is to stop the compulsive drug disorders, and it's obviously going to be more effective to stop this than to have the incarceration, which is going to cost more than the drugs itself. So the duration of treatment, at least 3 months, is usually needed to achieve a positive outcome. Holistic treatment address multiple needs, not just a drug addiction, due to psychological and physiological behaviors and aspects of the abuse. So this is going to be a lot of the psychological disorders that are going to develop, and the physiological illnesses and the physiological symptoms that they're going to have to develop. Like maybe they have heightened induced stress, which is going to lead to, like we learned yesterday, which is going to lead to a heightened blood pressure. They're going to have lower stress tolerance. They're going to have immunosuppression and maybe autoimmune disease. It's also going to develop that constant perpetual sympathetic nervous state, which is going to obviously allocate a lot of the nutrients in the body towards a lot of the things that is not going to be needed at a resting state. But since they're constantly anxious, it's going to induce a lot of that fight or flight response that Walter Cannon covered. Group therapy, addicts are more likely to maintain sobriety in a group of a format due to the rewarding therapeutic benefits of a group, such as support, affiliation, identification, and even confrontation. Parental involvement correlated with greater reduction in use by teen substance abusers. Sociocultural model, the perspective that looks at you and behaviors and symptoms in the context of your social background. How does your cultural religious beliefs affect your attitude towards mental health treatment? Cultural competence, a mental health profession must understand and address issues of race and culture and ethnicity and use strategies to effectively address the needs of various populations. Multicultural counseling and therapy integrates the impact of cultural and social norms and aims to work with clients to define goals consistent with their life experiences and cultural values. This strives to recognize the client's identities to include individuals' group and universal dimensions. This advocates to use the universal cultural specific strategies and the role for the healing processes, and it balances the importance of individualism and collectivism and assessments of diagnosis and treatment of clients. So treatment barriers assess the availability of mental health disorders, lack of insurance, transportation, or time. Even when access is comparable among a racial ethnic group, minorities utilize mental health services less than white middle-class Americans. Ethnic disparities, lack of bilingual treatment, stigma, fear of being understood, family and privacy, lack of education and mental illness, perceptions of attitude, self-sufficiency, and not seeing the need for help, not seeing therapy as effective, concerns about confidentiality, and fear of psychiatric hospitalization or treatment itself. So what this is saying is, obviously, a lot of these people with these ethnic backgrounds and ethnic disparities are going to have this systematic racism that's going to be going on with some of these ethnic groups, and these ethnic disparities are going to create this hindrance on a lot of money, which is obviously going to hinder them getting that mental support, because we need money to be able to participate in a lot of these activities and to be funded by these activities. So, yeah, and the perceptions, the attitudes, self-sufficiency, not needing help, they're going to feel like they don't need help, not seeing therapy is effective, and concerns about confidentiality. So a lot of these people, it's going to be prominent throughout their society. They're going to have this individualistic ideology maybe that they don't need help, and they're going to try to isolate themselves, and they're going to try to help themselves and feel like they don't need any external help. They don't need anything. And it's going to cause a stigma, and it's going to cause them to have these perpetual symptoms until they finally realize that they actually need therapy. So, yep, that is going to be it. Only 37 chapters, and this will be the ending of Introduction to Psychology for me, and maybe for you. I don't know. I might go into psychology deeper, but I definitely enjoyed this chapter, and I hope you guys enjoyed my lectures on the chapter. And I probably will be rewatching these later. But thank you guys so much for listening to my chapters. Hope you guys enjoy your day. It is Thanksgiving right now, so if you're watching this today, happy Thanksgiving. Peace out.